Across the United States, millions of women in their 40s and 50s are doing what they've always done: holding up hospitals, running classrooms, keeping entire workplaces running on fumes and grit. But when menopause hits, the system they've been holding up often has nothing for them: no clear benefits, no training for their doctors, no workplace policy, until now. In just 1 year, at least 13 states have put menopause on the policy map, introducing more than 20 bills to expand care, education, insurance coverage, and workplace protections. Women now make up almost half of the U.S. workforce, and participation among prime age women has reached near record highs. For many, the peak of a career now lands in the same decade as the peak of menopause symptoms. And for millions of midlife workers, menopause isn't just a health transition, it's a performance review, a question mark over a career. 13 states signaled they were ready to change that, but only 3 made it all the way to real protections. The gap between those numbers tell an uncomfortable story about who gets support, who gets overlooked, and who's still expected to push through in silence. Up to now, menopause has mostly been treated as a private, personal problem, something you manage quietly with extra layers, portable fan, over-the-counter remedies, and a smile at work so no one notices. If you can't sleep, if your memory slips, if your mood crashes, the assumption is that you need to cope better, not that anything around you needs to change. But we are entering an era of change. At first glance, the bills introduced across 13 states look scattered. Different sponsors, different wording, different priorities. But when you study them closely, patterns begin to emerge. No matter the state, every menopause bill touched one of 3 themes. Some say, teach it; others, pay for it; while another group call to protect it at work. Education, coverage, workplace rights. The entire policy landscape rests on those 3 ideas. Rhode Island is the first state to introduce House Bill 6161. It named menopause explicitly as a workplace condition that deserved recognition, protection, and accommodations. On June 24, 2025, Governor Dan McKee signed into law Bill No. 6161, amending the Rhode Island Fair Employment Practices Act, RIFPA, to include menopause, perimenopause, and related medical conditions as protected categories under the law. The bill expanded the state's existing Fair Employment Practices Act, placing menopause and related conditions alongside pregnancy and childbirth in anti-discrimination law. Lawmakers framed menopause not as a private inconvenience, but as a predictable stage of life that the workplace had simply failed to keep up with. Supporters argued that the accommodations were modest: access to cooling, extra breaks, flexible scheduling, but the impact could be life-changing for workers dealing with heat intolerance, heart palpitations, or sleep deprivation. Opposition was surprisingly limited, because Rhode Island wasn't creating a brand new system. It was expanding an existing one. Employers were already required to offer reasonable accommodations for pregnancy. Menopause, lawmakers said, was just the other end of the reproductive lifespan. In hearings, witnesses spoke plainly. This is not special treatment. This is how you retain experienced workers. And in the end, that argument won. Rhode Island's law doesn't wait for menopause to be classified as a disability. Employers must engage in a good faith process and offer reasonable accommodations, even if the worker wouldn't qualify as disabled under federal law. And the state doesn't let those rights sit quietly in a statute book. Employers have to post notices, give every new hire a written explanation, alert all current employees, and even provide a rights notice within 10 days when someone tells them they're pregnant or in menopause. In other words, Rhode Island didn't just add the word menopause to an old law.
A new menopause workplace policy. This policy allows you to request reasonable accommodations privately through HR. This includes reasonable accommodations like flexible breaks, temperature control law, and schedule adjustments.
It built a system that tells workers out loud,
You're covered, and you're allowed to ask.
California took a different approach. In California, the stakes are enormous. The state has one of the largest healthcare systems in the country and one of the largest populations of midlife women trying to navigate it. When menopause symptoms arrive here, they don't just collide with work. They collide with an overburdened medical system that often isn't trained, reimbursed, or structured to respond. Instead of starting in the workplace, lawmakers went upstream into medicine and insurance. In 2024, and again in 2025, legislators introduced the Menopause Care Equity Act, a sweeping proposal that aimed to close two gaps at once. First, it would require health plans regulated by the state to cover medically necessary menopause care, including hormone therapy and non-hormonal treatments, without treating it as optional or cosmetic. Second, it would strengthen clinician education, allowing menopause training to count toward continuing education requirements for licensed health professionals. The premise was simple. If doctors aren't trained and care isn't covered, women never reach the starting line. The bill gained traction quickly. It passed through committees. It cleared both chambers of the legislature. Supporters framed it as a matter of equity and economic sense, arguing that untreated menopause symptoms already cost the state billions in lost productivity and health complications. Twice, California's legislature said yes. Twice, the governor said no. Governor Gavin Newsom vetoed the Menopause Care Equity Act, both times citing concerns about expanding mandated insurance benefits and the potential impact on healthcare costs. In official statements, the vetoes acknowledged the importance of menopause care, while stopping short of requiring insurers to pay for it. So why did California, often seen as a policy bellwether, draw the line here? Part of the answer lies in scale. California regulates massive insurance markets. Even small coverage mandates ripple outward, affecting premiums for millions of people. Business and insurance groups warned that adding menopause care to the list of required benefits could set a precedent, opening the door to other condition-specific mandates. Supporters countered that menopause is not a niche condition. It's a universal stage of life for half the population. But in the end, California revealed a familiar tension, a willingness to name the problem, paired with hesitation to bind the system to pay for it. If you live in California, the picture is mixed. Menopause training is gaining legitimacy in the medical profession. Awareness is growing. But comprehensive, guaranteed insurance coverage for menopause care remains uneven, dependent on your plan, your employer, and your ability to pay. California signaled cultural readiness. It stopped short of structural commitment. California's story isn't about indifference. It's about limits, where acknowledgement ends and obligation begins. And it raises a question every state is now facing. Is recognizing menopause enough, or does real support require putting it into law? New Jersey moved with a different kind of urgency, not just to acknowledge menopause, but to make the system pay attention where it matters most, in the doctor's office and at the insurance counter. Lawmakers didn't frame menopause as a niche issue. They treated it as a mainstream health reality for millions of women, and by extension, a workforce issue hiding inside the fine print of coverage. The proposals here aim to close two gaps at once: care that's covered and clinicians who are trained so women aren't left doing guesswork in the waiting room. In New Jersey, the question wasn't whether menopause is real. The question was whether the state would make it treatable and affordable in a way that actually reaches working women. New Jersey lawmakers introduced A5278, known as the New Jersey Menopause Coverage Act. The goal was straightforward: require health plans to cover medically necessary perimenopause and menopause care, not just a narrow slice of treatment. The bill wasn't vague. It spelled out a broad list: hormonal and non-hormonal treatments, behavioral health care, pelvic floor physical therapy, bone health treatments, preventive services tied to menopause-related risks, plus counseling and education on menopause management. A 5278 moved in the Assembly. It passed the Assembly unanimously in June 2025. By October 2025, it was received in the Senate and referred to the Senate Budget and Appropriations Committee. That last step matters. When coverage is the policy lever, the debate almost always turns to cost, budgets, and who pays. But New Jersey didn't just ask who would pay. It also pushed the importance of teaching it. New Jersey advanced A5309, paired with Senate Bill S4147, Menopause Provider Education Bill, to allow clinicians to apply menopause education toward license renewal. This bill actually made it through both chambers in 2025, and then hit a policy checkpoint, a conditional veto from Governor Phil Murphy. The lesser-noticed detail is why the governor sent it back with recommended changes. The message wasn't no training. It was, don't build an unfunded state program inside the Department of Health, and don't accidentally imply menopause education is capped. In other words, keep the spirit, simplify the machinery. And as of mid-December 2025, the bill is in the concurrence with governor's recommendation stage, meaning lawmakers are still completing the final steps needed to turn that agreement into enacted policy. New Jersey's approach shows a pattern you'll see across the country. Education is often the first lever states can move because it's politically easier, cheaper, and framed as quality improvement. Coverage, by contrast, triggers deeper budget math and federal guardrails, so it tends to slow down in committee rooms. It's not that lawmakers don't understand menopause. It's that systems move fastest where the funding question is simplest. For midlife workers, this isn't theoretical. When training is missing, symptoms get minimized. When coverage is missing, care becomes a luxury. And when both are missing, menopause turns into a performance problem instead of a health transition. New Jersey didn't try to make menopause inspirational. It tried to make it legible inside healthcare systems. And the fact that one bill is still waiting in committee while the other moved, stalled, and returned tells you exactly where the real friction lives. Not in the science, but in the system. But what happens when size, unions, public sector work, and politics all collide? Scale becomes everything. New York changes the scale of the conversation. This is a state with millions of women in the workforce, across hospitals, schools, transit systems, offices, and city agencies. When menopause shows up here, it doesn't stay private for long. It collides with unions, public sector rules, insurance systems, and some of the most demanding jobs in the country. In New York, the question wasn't whether menopause exists. It was whether a system this large could make room for it. New York didn't approach menopause with a single sweeping bill. Instead, lawmakers introduced multiple proposals, each aimed at a different pressure point inside a very large system. Some focused on education, calling for better menopause training for clinicians and public awareness initiatives. Others focused on workplace protections, especially in public sector jobs where rigid schedules, physical demands, and union contracts shape daily life. And some proposals simply tried to name menopause in policy language that had never acknowledged it before. Even as statewide legislation moved slowly, something else began to happen. Menopause entered the conversation at the local and institutional level. Large employers, unions, and public agencies began experimenting, adding menopause to wellness programming, manager training, and internal policy discussions. These weren't mandates, they were workarounds. In a system this big, change often starts not with a law, but with pressure from the ground up. As of now, New York has not passed a comprehensive statewide menopause law comparable to Rhode Island's workplace protections. Bills have been introduced, hearings have been held, language has shifted, but in a state this large, with layered authority and competing priorities, progress has been incremental. Menopause is visible in New York. It is not yet structurally guaranteed. So why does New York, often seen as a policy leader, move so carefully here? The answer lies in complexity. New York's workforce is deeply unionized. Its public sector rules are layered. Authority is split across state agencies, city governments, and independent systems. Any statewide menopause policy has to fit inside collective bargaining agreements, civil service rules, insurance structures, and local governance. That doesn't make change impossible. It makes it slow. In New York, the question isn't whether menopause matters. It's whether a system this large can move in one direction at the same time. If you live and work in New York, support may exist, but it's uneven. It depends on your employer, your union, your agency, your insurance plan. Menopause here is increasingly acknowledged, but still navigated individually. New York shows what happens when scale becomes the story. Not denial, not indifference. But a system so large that even necessary change has to fight gravity. Massachusetts went straight for the infrastructure of menopause care. Not a headline-grabbing mandate, but the scaffolding, training, standards, and a statewide plan. One of the clearest examples is House Bill H. 4838, an act expanding access to perimenopause and menopause care. The bill does two concrete things. First, it creates a special legislative commission to map what menopause care should look like statewide. Second, it pushes the teach it lane into licensure. It requires a one-time training on perimenopause and menopause care as part of continuing education for multiple licensed professionals, including physician assistants, registered nurses, and practical nurses, with the requirement targeted to those who serve perimenopausal and menopausal age populations. This is Massachusetts saying, if clinicians aren't trained, access doesn't exist on paper or in practice. Alongside that, Massachusetts has H2 499, a broader menopause awareness approach aimed at public, medical, and workplace understanding of menopause and related chronic conditions. In other words, not just care, but literacy, because stigma thrives where information is missing. Massachusetts is building the foundation, commissions, education standards, and awareness infrastructure. Policy moves designed to make menopause care normal, routinized, and teachable. As of December 2025, Massachusetts has not enacted these menopause bills into law. They're still in the legislative process. H 2499 remains in the Joint Committee on Public Health, with its reporting deadline extended into March 2026. H4838 is also positioned in the public health track, meaning Massachusetts is still building momentum rather than delivering a final statewide guarantee. Yet, Massachusetts is the teach it strategy in motion. Normalize the training, build the framework, and prepare the system. The question is whether it will convert that groundwork into enforceable rights. Illinois didn't debate whether menopause was real. It decided whether it should be covered. In 2023, Illinois passed one of the most consequential menopause laws in the country. The state enacted legislation requiring private insurers and Medicaid to cover menopause-related care, including hormone therapy and medically necessary treatments tied to the menopausal transition. This was a structural shift. For years, menopause care lived in a gray zone. Prescriptions denied, visits coded as optional, treatments framed as lifestyle choices instead of medical needs. Illinois removed that ambiguity. If care is medically necessary, coverage is not optional. House Bill 5295 requires group and individual health insurance plans in Illinois to cover medically necessary hormone therapy and other treatments for menopausal symptoms when recommended by a qualified provider. The law amends the Illinois Insurance Code so that insurance policies issued or renewed on or after January 1st, 2026 must provide coverage for hormonal and non-hormonal treatments for menopausal symptoms, including all FDA-approved modalities such as oral, transdermal, topical, or ring formulations when medically necessary. Illinois didn't frame menopause as a workplace accommodation issue. It didn't wait for employers to decide what support looked like. Instead, it placed responsibility where healthcare decisions usually belong, inside the insurance system. Illinois lawmakers treated menopause as part of the reproductive lifespan, not a special category. That framing mattered. By positioning menopause alongside pregnancy, postpartum care, and preventive women's health, the bill avoided the niche condition trap that stalls legislation elsewhere. If you live in Illinois, menopause care is no longer something you have to argue for. Coverage is built in. The question shifts from, will this be covered, to, is my care good enough? Illinois proves something important. When a state decides menopause is standard health care, the system can adjust. The barrier was never medicine. It was whether policymakers were willing to pay for what they already knew. If Illinois proved coverage could pass, Louisiana proved something else. Menopause policy isn't regional, and it isn't partisan. In Louisiana, the bill had a name, and it became law. House Bill 392, enacted as Act 784, passed in 2024 and took effect on August 1st of that year. Act 784 requires both Medicaid and state-regulated private insurance plans in Louisiana to cover perimenopause and menopause care when a licensed provider determines it is medically necessary. That includes hormone therapy and other approved treatments, not as optional benefits, but as standard coverage. One detail changes how this law works in real life. Louisiana's law limits common insurance delays, including prior authorization and step therapy requirements, the fail first rules that often slow or block care. In practice, that means fewer delays between diagnosis and treatment. Louisiana didn't frame menopause as a workplace accommodation issue. It didn't require women to prove disability. And it didn't ask employers to decide whether care was justified. It placed responsibility squarely inside the healthcare system. If you live in Louisiana, menopause care is no longer something you have to negotiate. If your provider says treatment is medically necessary, coverage is required. The burden shifts away from patients and onto the system. Louisiana matters because it dismantles a common assumption that menopause coverage only moves forward in certain regions or under certain politics. Illinois and Louisiana arrived at the same outcome through very different paths. Together, they answer a question many states are still debating. When menopause is treated as standard health care, systems adapt. The remaining question isn't whether this can be done, it's who's willing to do it next. After Illinois and Louisiana, Texas is the contrast. The conversation got loud, the proposals were real, but the finish line stayed out of reach. Texas introduced House Bill 3814, a bipartisan measure to require health benefit plans to cover prescription medications used to treat perimenopause and menopause. It was filed in March 2025 and sent to the House Insurance Committee. But it did not advance into a statewide coverage guarantee. It stalled at the committee stage. So for Texans, coverage still depends on your plan, your employer, and what your insurer decides to recognize. Texas also introduced House Bill 3961, which would have created a perimenopause and menopause educational program through the Department of State Health Services. That bill was referred to the House Public Health Committee, and it also did not become law. Texas didn't reject the idea that menopause affects health and work. The bill simply didn't make it through the machinery, where timelines, competing priorities, and committee calendars decide what lives and what dies. Even local news noted the moment as unprecedented. Texas among the states considering mandated menopause treatment coverage. Texas shows the gap between proposing a policy and delivering protection. The question wasn't whether menopause exists. It was whether the system would make room for it in time. Virginia's move wasn't branded as a menopause bill at all. It was a women's health education bill that quietly widened the lens. In 2025, Virginia passed House Bill 1918, creating a statewide women's menstrual health program inside the Virginia Department of Health. It was approved May 2nd, 2025, and takes effect July 1st, 2025. HB 1918 directs the Department of Health to deliver education and training for healthcare providers, emergency-facing hospital staff, and the public, and to post clinical guidelines and educational materials online. Here's the subtle point. The bill's language acknowledges these conditions can reach beyond period problems. It defines endometriosis as something that may also occur in postmenopausal individuals. So Virginia's message is, women's health doesn't stop at reproduction. Education has to cover the full lifespan, and that includes midlife. Virginia didn't pass a menopause insurance mandate here. It didn't create workplace accommodation rights. It built a state-run education infrastructure. This is a systems-building move. It's intended to reduce dismissal, delays, and mistriage by making providers and hospital staff more prepared. It does not create a menopause insurance mandate or a menopause-specific workplace accommodation right. It builds the groundwork, better training, better guidelines, and better public information, so women aren't left navigating symptoms in the dark, and sets the kind of groundwork that makes menopause policy easier to pass later. Connecticut's approach was narrower, but more explicit. Lawmakers introduced proposals that name menopause directly and pushed for better education and awareness inside healthcare and public systems. The bills in Connecticut focused on education, making sure menopause is understood by health professionals and treated as part of women's health across the lifespan. The goal wasn't coverage mandates or workplace rights, it was recognition, getting menopause out of the margins and into formal guidance, training, and public health conversations. As of now, Connecticut's menopause proposals have not been enacted into law. They remain part of the legislative conversation, introduced, discussed, and referenced, but not yet converted into binding statewide requirements. For Connecticut residents, that means support still depends on where you receive care and how informed your providers are. There's no statewide guarantee, but there is a growing acknowledgement that menopause belongs in health education, not just private conversations. Connecticut shows how many states start by teaching first, by naming menopause inside the system, and by laying groundwork that makes stronger policy possible later. In Wisconsin, menopause policy entered the legislature through a specific proposal. Lawmakers introduced Senate Bill 356 with a companion measure, Assembly Bill 381. The bills focused on education. They proposed expanding awareness and training around perimenopause and menopause, recognizing them as legitimate health transitions that affect diagnosis, care, and everyday functioning. This was a teach-it approach aimed at reducing dismissal and misrecognition by making sure menopause was formally named inside health systems. The proposal moved into the legislative process and was taken up by committee. It advanced through early steps, including committee review, but it did not reach final passage. No statewide training requirement was enacted. No binding mandate followed. Wisconsin matters because it shows how fragile early momentum can be. Even naming menopause doesn't guarantee action. Without sustained pressure, dedicated policy vehicles, or clear understanding of impact, proposals can stall quietly. For people living and working in Wisconsin, menopause care and support still depend on individual doctors, individual employers, and individual plans. There is no statewide guarantee, only the beginnings of recognition. Wisconsin is a reminder that progress doesn't always fail loudly. Sometimes it just pauses. Colorado's approach was modern and methodical, not a single sweeping menopause law, more like a policy lab, awareness, standards, and groundwork that can be scaled. Colorado lawmakers entertained proposals that push menopause into public systems in 3 ways. Teach it, improve education and clinical readiness. Protect it, encourage workplace policies that treat menopause like a normal health transition. And normalize it, make menopause visible in public health planning so it's not left to personal coping. But Colorado's proposals did not become a single statewide menopause guarantee. They reflect momentum, not final protection. The state moved the conversation forward, but the legal finish line is still uneven. For Colorado residents, support is still real, but inconsistent. It depends on which health system you're in, what your plan covers, and whether your workplace has modern accommodations. Colorado is building readiness, but readiness isn't the same as rights. And that gap between preparation and protection is where the next decisions will be made. Oregon is what it looks like when a state decides menopause care isn't optional, but standard. This year, Oregon advanced House Bill 3064, requiring coverage in state-regulated private plans, plus public employee and educator plans. The bill moved. It passed the House and Senate, then was signed by Governor Tina Kotek on July 17, 2025. HB 3064 doesn't just say menopause care. It lists categories of treatments that plans must cover, including hormone therapy, including combination, estrogen, hormone, estrogen, progesterone, and estrogen only, SSRIs and SNRIs, vaginal estrogen, medications to treat osteoporosis, neurokinin B antagonists, topical hormone therapy, bioidentical hormones. That specificity is a big deal because it reduces the "we cover menopause," but not that loophole. Coverage requirements apply to plans issued, renewed, or extended on or after January 1st, 2026, plan year 2026. Oregon doesn't treat menopause as a private endurance test. It treats it like what it is, a predictable stage of life that deserves routine care. Across 13 states, menopause finally entered the record. Some states said they will teach it. Some will pay for it. Some promise to protect it at work. Only a few carried all three to the finish line. This wasn't a wave, it was a signal. Because menopause isn't rare, it isn't optional, and it isn't a personal failure to manage quietly. It's a predictable stage of life, experienced by millions of workers, patients, caregivers, and leaders at the same time. What these 13 states revealed isn't just where policy succeeded or stalled. They revealed where systems are still deciding who adapts and who is expected to endure. The question is no longer whether menopause belongs in public policy. It's whether readiness becomes rights. Because when a health transition is universal, silence is no longer neutral.